with the March webinar. All right, I'm going to go ahead and kick things off. Welcome to the March Resuscitation Academy webinar. We are very excited today to have one of our own host the webinar and chat with us a bit about the latest update in science. Peter Kudenchuk is a name I'm sure pretty much everybody on this call knows. Peter's a fantastic EMS physician. Peter is a one of the rare, maybe the only cardiologist, electrophysiologist, EMS medical director combination in the country that I know of. Maybe Peter knows of another one, but I don't think there are any. And he does a great job at all of those things, right? He's a fantastic educator. If you go to our YouTube channel, our #1 video is Peter's The Science of CPR with over 55,000 views. I don't think he knew that part. Uh, and it's a series of talks that Peter has evolved over the years and really lay the groundwork for what we do at the Resuscitation Academy, where all of our improvement is based on science. Peter has been a longtime member of the faculty here at the RA, a longtime member of the faculty at the University of Washington, medical director for King County Medic One, which covers a large portion of King County as for the ALS coverage, and just an all-around great guy and good friend. Welcome, Peter. Thank you so much for agreeing to give this talk and rearranging your schedule to be here with us. We appreciate it tremendously, and we are excited to hear updates in the research around the science of CPR and cardiac arrest. Take it away.
Sounds good, Andy. Thank you. Your check's in the mail for the compliments, and I expect a check in the mail for the 55,000 views of a topic that I think people have heard too often already. What I want to do is talk a little bit about IV versus IO vascular access and cardiac arrest, giving you a little bit of a feel for both the ins and the outs of where guidelines now kind of fall on this particular issue. What do we know about vascular access? Peripheral vein access has been the standard, as you all know. It's the one way we can assure drug delivery occurs. But there's a problem, and that's the issues of variable success. Can range anywhere from 18 to 98%, depending on the study you look at, can often require multiple attempts. And the problem is it's heavily patients and operator dependent. That can create challenges. Central vein access has also been used, less commonly now. Its advantage, as you can see in the graph, showing much higher peak drug levels and faster delivery compared to the black line, which is peripheral access. And although you get a bigger bang for the buck, the challenge with central vein access is it takes time to get it in, probably longer than peripheral IVs. And if you're doing it during CPR, you have to pause CPR to do it. And it's heavily dependent on skills and complications, skills of the provider and the complications that can occur when you don't do it the right way. But it's still out there and something that offers an alternative. The other approach has been to recognize that bones, although they're structural, they keep us upright, is also a vascular structure. And if you puncture bone in the right place in the right bone, you hit marrow, and the little trabeculi and compact bone actually connect with vascularity because bone is supplied by blood to keep it alive. And it provides another route by which drugs can be given if intravenous access is not really feasible. And there's been a growing use of IO access for that reason, particularly in EMS settings where veins may be hard to find, take longer to get access, and it becomes a convenient way, particularly now with the bone drill, to drill your way to success rather than poke your way and not find a vein in process. And successive tibial IO access in particular is very high. It's hard to miss bone, and perhaps triple the likelihood of success with a peripheral IV. IO access is also touted to be faster than getting an IV, 1.5 minutes versus more than twice that in some studies. And if you have patients in a normal or near normal circulatory state, you get comparable drug effects. So giving antibiotics, morphine, fluids in those circumstances, IO and IV are pretty much comparable. But there are issues, and that is if you have a low flow state like CPR, the pharmacokinetics differ, whether you give drugs IV or IO. And there may also be differing effects between the kinds of drugs that you would give, drugs that are lipophilic versus those that are hydrophilic, meaning ones that are fat soluble versus ones that are water soluble. And that can create a difference. And to just give you a feel for where we have data, it comes a lot from animal models and frankly, often small models. Here's 21 pigs who were put in VF. Mechanical CPR was instituted. Epinephrine was given, followed by a 20 cc flush into 3 groups, 7 pigs in each group. Tibial IO with a 15 gauge IO, humeral IO, 15 gauge, or an auricular vein in the pig's ear, 18 gauge IV. And in the study, they gave epi, flushed it in, continued CPR, and then they checked plasma levels for epi concentrations every 30 seconds. So you go over the time period, 30 to 240 seconds. Here's the mean epinephrine concentration given IV, given by humeral placed IO, and given by tibial IO. And in these animals, what was observed, as the graphs would suggest, is that of the 3 approaches, tibial IO tended to be the least effective. You had the lowest concentrations over time, and humeral IO fell somewhere in the middle, but the difference between IV and humeral IO was not statistically significant. That was borne out, and this is another way of presenting this graph by saying what was the peak concentration of epinephrine achieved, whether you gave the drug IV, humeral IO, or tibial IO, and the highest concentration was achieved with IV, and tibial tended to be the lowest. The other question then was, what about the time it took to get epinephrine to its maximum level? And once again, the shorter time periods were with humeral IO and IV, and the longest intervention or longest time to peak epinephrine was with tibial. So this simply says that these approaches in low flow states are not quite the same as they would be in a normal circulation. The pharmacokinetics differ, and so although they're interchangeable, they're not quite the same. Problem number 2, and this may be one that is worth thinking about. If you talk about hydrophilic drugs, meaning drugs that are water soluble, epinephrine, vasopressin, and you do an IO stick and administer these drugs readily pass into the circulation, or at least with the limitations that the previous slide showed, but they get in pretty well. But the real marrow is highly fat concentrated. Marrow is 70% fat. And if you give lipophilic drugs like lidocaine, amiodarone, or dilantin, there's the concern that the fat may create a deposition of these drugs, slow the delivery of the drugs, and as a result, you may have less efficacy of these drugs than you might with drugs like epinephrine. And that's also been borne out, again, in small animal studies. Here's another one, 14 pigs, put in VF, mechanical CPR. They get a vasoactive drug, vasopressin, and then they were given 300 milligrams of amiodarone, either proximal tibial IO, or again, auricular vein in the pig's ear. And plasma epinephrine concentrations were sampled for 30 minutes, of every 30 seconds. Here's the mean concentration of amiodarone when it was given intravenously. And here's the mean concentration over time in minutes when the drug was given intraosseous. And although statistically this p-value is not significant, what's notable is that although the p-value is small, the actual level of amiodarone was more than twice the level achieved when the drug was given IO as compared to IV. And that difference, meaning a virtual doubling of concentration throughout the entire time course, was present from the beginning to the end of resuscitation. So although the p-value is not significant, it really makes you wonder, were you getting any bang for the buck with amiodarone given tibially? Here's another study done the same way, but this time amiodarone was given humeral versus IV. And the same approach. Here is IV amiodarone, and here is humeral amiodarone. And again, in this particular study, the maximum concentration when you gave it humerally was no different IV versus IO. And the time to maximum concentration was the same with both drugs. But notice the trajectory of humeral administration of amiodarone. It starts lower and it takes longer to get to those same levels, which again raises concern is, does the character of the drug, whether it's lipophilic in this case, affect the ability for the drug to have its effect? Well, there's the basic science, but where the rubber meets the road is, how do these drugs work in real life during resuscitation? And there are three large randomized trials that have been published in the last couple of years that address the speed of giving drugs IV versus IO, the success in giving drugs IV or IO, and the efficacy and ultimately effectiveness of these treatments. And let's look at these very briefly. The largest of the three trials, 6,000 patients, was done by the Brits. And to answer the question, how successful was IV versus IO in this randomized trial, where the initial choice was whether you place drugs IV or IO, and they were randomized in that fashion, is that the success rate of achieving IO was much higher than IV. That's something that one would expect. 74% of these patients received tibial IO. Just to give you a feel for the kind of patients randomized, 20% had shockable rhythms, and 94% of the time the drug was epinephrine, and 16% was amiodarone. Pretty similar in the Danish trial. Success of an IO versus IV was quite high, 97%. The Danes did better than the Brits, but still IO beat the success rate of IV. This trial was also stratified for tibial versus humeral IO. So about 50% of the patients in this trial got tibial IO and 50% got humeral. 23% of the arrests were shockable. And again, 90% of the treatment in this case was with epi, 17% amiodarone. The third trial out of Taiwan, and I have to tell you, this trial has now been I want to say rejected, but it's been disputed as to its accuracy, and so it's been withdrawn. But it was published in the BMJ, and it similarly showed success of 93% with IO versus 50-some% with IV, saying again you have higher likelihood of getting access with the IO approach. Humeral IO was 100% in this group, 29% shockable, and 68% epinephrine, 6% amiodarone. Now, let's talk about time, because I think maybe the first myth that these three trials really addressed and dismissed was whether you can get an IO in faster than you can get in an IV. So here are the times across the board: 911 to EMS arrival, EMS arrival to vascular access, and the bottom line, EMS arrival to when the drug was given, or 911 to arrival, and EMS to drug. And you can see that no matter how you cut it, you're talking about 15 minutes from the time that you plan to give a drug, or 911 is activated, until the drug is actually administered. And there was no time savings of any significance when IO was prioritized as the first drug line to be given for drug access versus IV. So the idea that it's faster is a myth. In randomized trials where you randomized to the two approaches, there was no real time savings. What about the efficacy of these administration? The likelihood of achieving sustained ROSC, discharge alive, and longer-term survival. Well, if you look at sustained ROSC, only one trial found that you had a higher likelihood of ROSC with IV. The other two trials showed no difference. But across the board, in terms of clinical outcome of survival, there were no differences between the two groups. So although maybe there's a difference in ROSC, there was no bottom line benefit in whether these drugs were given IV or whether they were given IO. And jumping to the Danish trial, where remember they stratified IO as humeral IO or tibial IO, they also saw no significant differences in ROSC, 30-day or 90-day survival, which I think suggests that you can't say that humeral or tibial IO are any better than IV. They're certainly no faster. And at least the data from these trials, one could argue, would say maybe it's equivalent. You don't get a bang for the buck, but you do have a higher success rate. Doesn't take more time to do it, and the outcome is the same. But let's look at another aspect of these trials. All of them primarily used epinephrine in the patients they saw, and the use of amiodarone in particular and antiarrhythmic drugs was a minority. And so these may address the question about hydrophilic drugs like epinephrine that readily penetrate the marrow and get into the bloodstream, and IVIO may be pretty similar, but they don't address the use of antiarrhythmic drugs. And let's talk about what about antiarrhythmics given IV or IO in patients with cardiac arrest. There is not a randomized trial that specifically addressed that question, but the ALPS trial, which randomized 3,000 patients with shock refractory cardiac arrest to amio, lidocaine, or placebo, had an a priori pre-specified hypothesis. And that is that given the drugs IV or IO may make a difference. So this prospective look at the data accumulated during ALPS asks this question: did the outcome differ between amio, lidocaine, and placebo, whether they were given IV or whether they were given IO? And as the breakdown occurs, whether the drugs were given one way or the other, an equal proportion of those patient groups got amio, lidocaine, or placebo, meaning a third in the IV group got one of the three drugs, and a third in the IO group were evenly distributed. Because the trial, and again, I'll back up, the IVs were typically in the arm, and in this particular trial, we're talking primarily tibial IO drug receipt. Because the trial is not randomized, you want to make sure that these two groups are readily comparable in their characteristics. And you can see that the IO group had a slightly smaller percentage of men, but public location of arrest was comparable, bystander witness was comparable, bystander CPR was comparable, call to EMS arrival was a little bit faster in the IO group. But look at these numbers here. 911 call to getting IO or IV access and time to study drug was virtually identical in the IV and the IO group. Again, underscoring what the randomized trials told us is that we're not talking about fast drug delivery. And if you then looked at these characteristics within the three groups of amio, lidocaine, or placebo, those characteristics, and likewise broken down by drugs, they pretty much look the same. So although the trial was not randomized, the groups were pretty comparable between the two. So here are the three endpoints that were addressed in the trial: admission alive to hospital, survival to hospital discharge, and neurological outcome. And because, again, this sub-study was not randomized, the outcomes were adjusted for age, sex, location of arrest, whether it was witness, bystander, CPR, time to drug, and study site. And 95% of the patients in the ALPS trial, those data were available and you can make that adjustment. So let's look at endpoint. Here's the likelihood of IV versus IO amiodarone achieving survival to hospital discharge. Everything to the left of the dotted line favors IO. Everything to the right of the line favors IV. So what was the likelihood of surviving to hospital admission if you got IV amiodarone against placebo IV versus IO amiodarone versus placebo IO? Well, if you gave amiodarone IV, you had about a 9% absolute improvement in survival to admission or a 23% relative improvement in outcome. Given IO, there's no effect. Survival to hospital discharge. If you gave amiodarone compared to placebo, IV, absolute survival improved about 5.5%, a relative improvement of 27%. Given IO, there's no effect whatsoever. Improved neurologic outcome at hospital discharge, a modified Rankin score of less than or equal to 3, a 4% absolute improvement in amiodarone versus placebo given IV, a relative improvement of 26%, same drug given IO, no benefit whatsoever. So, interesting perspective. If you gave amiodarone IV, you had improved admission, improved discharge, and improved survival to neurological outcome. Given IO, you might as well have given nothing at all. Now, remember, you can say, well, this was because amiodarone given IV was given sooner. Well, it wasn't. The two drugs were given exactly the same time. Could this be because the IO group just happened to be sicker patients, meaning they were tougher to get an IV into, they were older, there were other characteristics, and therefore it's because of the IO effect rather than, or the patient effect rather than the IO. But take a look at the placebo group. If IO had anything to do with other factors, why was the placebo outcome identical in the IV and IO placebo groups? If there was something bad about the patients, you would argue that this placebo group would have a lower survival, and it didn't. It was identical to the amiodarone group. Lidocaine, second drug that was studied, same outcome. Survival to hospital admission, given IV, 24% relative improvement, nearly a 10% improvement absolute. When lidocaine was given compared to placebo, that difference was not statistically significant. It did not cross the zero line. Survival to discharge, 23% improvement with amiodarone given IV. No benefit when lidocaine given IV was beneficial, but lidocaine given IO had no benefit whatsoever. Improved neurologic status at discharge, 17% relative improvement with lidocaine given IV, which was not statistically significant, but no benefit at all when it was given IO. And the same characteristics in terms of improved outcome with the drug given IV, but not statistically improved when given IO. And if you looked again at the placebo groups in the IV and the IO lidocaine sector, their outcome was exactly the same, suggesting that this was not a problem with the patients who got IO. It's the fact that IO was not an effective way of giving either amiodarone or lidocaine. And I might just say, when the ALPS trial was designed, we wondered originally if we should just have specified that only IV administration of these drugs should count because of the uncertainty of giving the drug IO. And had that been the case, this drug or this particular trial would have been a hands down win for antiarrhythmic drugs. If anything, it was clouded by the drugs being given IO, which made the results more neutral.
Hmm.
So, how do we put that together? Well, here are the three randomized trials, and here is the systematic review and meta-analysis that put those results together and observed these things. Initial IO versus IV access in out-of-hospital cardiac arrest did not improve time to vascular access, did not improve survival at discharge or 30 days, did not improve favorable neurological survival, nor could you say there were any differences in those outcomes whether you gave the drug via tibial or humeral IO sites. What is interesting is if you put these data together for the three trials and looked at sustained ROSC, IO was less likely to achieve sustained ROSC than IV. Now, remember, these trials primarily evaluated epinephrine. And if we think there's a difference between hydrophilic versus lipophilic drugs, these conclusions may only apply to that group. But if you throw in antiarrhythmics, and again, this is not a randomized trial we're talking about, you can argue that IO versus IV lipophilic drugs may have differing effects, and therefore the two means of administering the drugs may not necessarily be equivalent. So the question then comes is, how do we then decide what you give and what role you would give it in? And when all these data were looked at by the Heart Association, the bottom line recommendation says there's every reason to believe that the first attempt at vascular access should remain recommended as IV. There's enough uncertainty about IO access that it probably should not be relegated to anything than second-line therapy, meaning administered if attempts at IV access are not successful or not feasible, but otherwise not considered first-line therapy. And I hope that at least the data that I've shared with you at this point may make that point. So here's the challenge that we have. The challenge is whether you give drugs IV or IO may or may not make a difference. The real challenge is time, because time to treatment makes a huge difference in terms of outcome from cardiac arrest. Let me take you back to the randomized trial that looked at epinephrine versus placebo in cardiac arrest. Here were the outcomes of the trial: admission alive, amiodarone versus placebo, discharge alive, and 30-day survival. And we saw statistically significant benefit by giving epinephrine in patients with cardiac arrest. But notice how small those numbers were. If you talk about 30-day survival or discharge alive, an absolute improvement of only 1%. I mean, that's a pretty small number. And if you look at neurological outcome, there was no difference whatsoever in terms of any sort of benefit. And look at the time that it took to administer epinephrine in this trial. 21.5 minutes for epi, 21 minutes for placebo. And you can argue, would anything work very well when given that late? The recommendations that came out for the use of vasopressor therapy and epinephrine in cardiac arrest was the emphasis: give it as soon as you possibly can. But even with IO access, we're not doing a whole lot better than when the drug's given IV. And it begs the question, what about another route? What about giving drugs, particularly epinephrine, intramuscularly rather than intravenously? And what do the guidelines have to say about that? Well, I'm glad you asked that question. because that particular approach was recently studied in an observational study from the group in Utah. And what they did in this particular trial, or particular study, is they looked at a pre-intervention control, about 900 patients, when IV or IO epi was given per standard care. And they compared it at a later post-intervention group where they changed the protocol. And they gave 5 milligrams of epinephrine by paramedics IM. And then as soon as they could get an IV or an IO in, they went and gave additional epinephrine. And they looked at the time savings in doing that. From EMS to epinephrine, when you gave it IM, was about 7.8 minutes, nearly twice as long as if you didn't give it IM, was about 7.8 minutes, nearly twice as long as if you gave the drug IM initially. So you could save 4 minutes. And from 911 to epi, given IV or IO, was 15 minutes, but you could cut that down to 12 minutes if you gave the first hit IM. So the question then is, did you get a bigger bang by giving the drug IM or waiting to give the drug IV or IO? So the group looked at these 3 endpoints: hospital admission, giving the drug IM versus strictly IV/IO, survival to discharge, and favorable neurological outcome. And across the board, they saw statistically significant benefit if you gave IM epi before IV/IO in terms of hospital admission, discharge alive, and favorable neurological status. And that set a lot of excitement in emergency circles, saying, have we finally found a route of drug administration that can be given very early and solve the problem of late treatment and how we would go about doing it? But wait a minute. Whenever you see data like this, you want to take a step back and say, is this biologically plausible that giving a drug like epinephrine IM would make a difference? So the Danes published a pig study that mimicked how this particular clinical study was done. 36 pigs in cardiac arrest were randomized to get early IM epi 5 minutes before IV epi. Here's the coronary perfusion pressure during CPR that was observed in this study. This is pre-arrest. Epinephrine was given IM during this 2 to 5 minute period. And the effect it had on perfusion pressure to the heart in these pigs, depicted by blue as IM epi and placebo as red, there was no difference in perfusion pressure whether you got IM epi or not. Those differences were not significant. And in fact, what the study concluded using the same protocol, there was no immediate hemodynamic effect from epi. It did not increase return to spontaneous circulation. In fact, there was prolonged absorption when you gave epi-IM, creating a depot effect such that the high epi levels were only seen 30 to 60 minutes after return to spontaneous circulation. So the bang from IM epi in this pig model was not immediate. It was after ROSC was already restored. So what does the Heart Association say about IM epi? Well, 3 things you'll see in the guidelines. Number 1, high-dose IM epi has a different pharmacokinetic profile than traditional IV drug administration. That was observed in the pig trial. Number 2, if you take a close look at the clinical study that was done, the heart viewed it as seriously flawed. It was non-randomized and unblinded, so automatically bias is created. There were a lot of confounders. The study was conducted over 14 years. Now, a lot can happen in that 14-year period. Recall misclassification of what actually occurred, compliance to the protocol, and maybe most important, evolving patient and treatment patterns that might have an effect on this outcome apart from the intervention itself. Bottom line is what the Heart Association said is further study is needed to evaluate the potential benefit of high-dose IM epi in cardiac arrest and therefore no recommendation is possible. But the bottom line is not ready for prime time. The feeling is that this is not a treatment that yet should go out in general care without more information and more data, and frankly, more studies than what we have at this point. Well, let me just sum up by saying we at this point know that drug treatment is not as fast as we want it to be. And the ideal way of giving drug therapy is still one of those where we're in a conundrum of effect versus speed and other issues. But I may just say it's not just what drug we pick or what drug route we pick, but how well it's given that actually matters. And let me share that with you by talking about quality of CPR. Here's a study that looked at the effect of drug delivery and drug effect in relationship to the quality of CPR. It looked at, again, a pig study, instrumented pigs who were measured aortic and right atrial pressure, venous pressure, and Doppler cortical blood flow. They were put in VF for 4 minutes, got BLS care for 4 minutes, and at that point, they were randomized to either receive ALS quality care with good CPR, which in this case was mechanical CPR at 100 compressions per minute, asynchronous chest compression, and 12 breaths per minute, and depth of 45 millimeters. Or they got deliberately poor CPR, manual rather than mechanical chest compressions, interrupted chest compressions for ventilation, creating a 9-second pause for each ventilation, and substandard compression depth of 30 to 38 millimeters. At the outset of ALS care, which went on for 14 minutes, they got a standard dose of epinephrine. And the question was, what was the effect of epinephrine given in context of good CPR or CPR that was not optimal? The first question was, how long did it take for epinephrine to peak, whether you got good CPR or poor CPR? Well, to peak epinephrine, if you got poor CPR, it took nearly twice as long to get the effect as when the drug was given with good CPR. 90 seconds median time to an epinephrine level versus 1.5 to 2 times that amount. Next question was, what effect when you were doing poor CPR did epinephrine have at its peak effect on coronary perfusion pressure? And here's median pressure, poor CPR, pre-epinephrine, post-epinephrine, no significant difference whatsoever. On the other hand, if you did good CPR, even before you got epinephrine, you had higher coronary perfusion to the heart, but after epinephrine, it increased even further. CNS blood flow. Oops, let me backtrack here. CNS blood flow, in the absence of good CPR, baseline, no difference in CNS blood flow was seen after epinephrine when CPR was not of high quality. On the other hand, if CPR was of high quality, you got better brain flow before epi and a significant improvement after epinephrine was administered. So here's what was observed. Poor CPR, no bang for the buck for coronary perfusion from epinephrine, and no benefit from epinephrine when you had, in terms of CNS blood flow in the context of poor CPR. On the other hand, if you did good CPR, you got a bigger bang from epinephrine for coronary perfusion and a bigger bang to brain perfusion as a result of improved CPR. The way I might put that together is saying the argument here may not be whether you give a drug peripherally, IO, central, endotracheal tube, or IM. It's the quality of CPR that really has to be done to get the drug on board, no matter what the route may be. And in all the studies we've looked at so far, the quality of CPR may have had as much of an influence as the method or route of drug administration. And in the systems that you currently practice in, what I might say is the practical point is whether you're favoring IO, whether you're favoring peripheral, or you're going some other route. The quality of CPR is going to determine its effectiveness perhaps much more than what the route is likely to be. So, how do we approach this in South King County based on the evidence that we have? Our initial approach in cardiac arrest is peripheral IVs whenever possible. If that's not possible, we will resort to a humeral IO, and we preferably do that over tibial just because of some of the data I've shared with you that's saying at least the kinetics appear to be better with humeral, even if at this point clinical studies haven't necessarily proved that. And once a humeral IO is placed, the medics will go back and see with giving some fluids IO, will they be able to pop up veins that would then be accessible peripherally? If peripheral IV and humeral IO are not adequate, we continue to place subclavian vein lines, but it requires indication, which would mean peripheral IV or IO are not satisfactory or not feasible, and then we'll go centrally in order to give access along the way. Now, I'm not saying this is the right approach, but I think in light of the data that we have, this is the way that I would stratify the approaches we have available. Where IM is going to fit into this, I have no idea, further studies. I will say that in the most recent guidelines, endotracheal administration of drugs is gone. It has been retired because there's no evidence of benefit, and therefore giving drugs in that manner is probably something that has gone by the wayside and not even a consideration in the present time. Andy, I was trying to leave it go until 2 o'clock so that you wouldn't have to ask any questions, but I failed miserably. So if
No,
there's
we
any
have some
concerns,
great questions in the chat, some great comments. I invited Tom, of course, and just sent an invite to Kevin Seaman, who raised his hand during your talk. I think he's got either a comment or some questions, but some super interesting insights here, Peter, that really is a fantastic review of the recent work that has been done on this topic, and really, really awesome. Tom, you want to lead off the commentary period?
Boy, I don't know that that was a really terrific review, and it's the way you tied in all the information. I thought it was, I guess, just one comment. I had not sort of registered that the survival in the placebo arms of the ALPS study were the same, regardless of um, the in the IO groups, the placebo arm survival, which really does make the case that it wasn't the patient factors, but that potentially could. I guess one very provocative question, Peter, that I mean, is it possible that maybe just drugs don't have any effect? Right? I mean, that would be the other explanation here. It's sort of not what I think. When I say effect, I mean sort of clinical benefits. I mean, could that explain sort of the null findings on all these things?
well, when you look at drug therapy on average 15 to 20 minutes after arrest, you wonder what time plays a factor in. And I'll draw an analogy, but it's probably not a fair one. If we waited for 15 minutes for the first shock, would we be using defibrillators saying they don't really save lives? So I think there's benefit in drugs. I mean, we see that even epinephrine had a 1% absolute benefit, small, but that was 20 minutes into the arrest. And I think that's where the enthusiasm for giving drugs faster may be the better way to know if they have an effect. IO isn't the answer to that. People are hoping IM will be, but I got to say, I'm skeptical until we see more studies whether that's going to be the best route to take. So I think time is the battle here.
Yeah,
And there is an effort to study that, right? I mean, this is an ongoing effort to get a clinical trial up and running of the IM delivery route, and trying to sort of see if the IM route and earlier administration makes a difference, and randomized to that, right? And there's been some real logistical challenges to get that done from speaking with Scott and others that are trying to do this effort. But I think that they'll overcome those eventually, and I hope we get an answer to that question because it's a very interesting one to me.
Yeah, and Andy, it's a fair point, and it's a credit to Henry and Scott that they're pursuing research. What I really want to caution is people who get excited enough about this, they start doing it automatically as part of standard care. And I got to say, that is human experimentation until we have trials. And I
Yeah.
think the heart would say the same thing. You have no business doing this unless you're studying it. If you're not studying it, you probably shouldn't be doing it.
So Peter, one last question. And first of all, that was a touche response. I agree. I think probably it is time sensitive, and so I would wonder if those prior studies, did a secondary analysis based on time, and although and you highlighted the Alps in terms of the route, um, uh, and if so, do we know that time, again, when the drugs are given early, I guess there are observational studies that suggest there's more benefit when the drug is given early as opposed to late.
Yeah, no, the time probably is a confounder, and the studies have looked at that, and the Brits looked at that. That earlier epinephrine, particularly in asystole PEA, seemed to have a bigger bang. But again, if you don't control for that in some manner, you have to be careful that the quality of care, apart from the drug, if you get the drug on sooner, may be having an impact that is assessing something other than the drug itself, the quality of care, for example, overall.
And last question, Peter, did they evaluate the quality of CPR? You really highlighted that, and I just wonder if that was evaluated in the trials of IO and IV. Did they look at
Yeah.
that?
Only in the ALPS trial was CPR looked at with that kind of scrutiny. I think in the other trials, not to that level or degree. So I think we just have to say that was probably average CPR, but it wasn't scrutinized at the same level as in ALPS, where performance was judged and reported in those individual groups.
All right, Peter, I'm going to jump to the chat. A couple interesting questions there. One is, in order to sort of smooth the epinephrine out and avoid these sort of plasma spikes that you might get with bolus infusion, is there any evidence that would support drip infusion or continuous infusion of epinephrine?
Yeah, good question. Um, there's a pig rock study that addressed that. When rock was completed, the thought was, wouldn't it be nice to have a multi-center animal trial to look at questions? And so pig rock was created and looked specifically at an infusion of epinephrine in pigs in cardiac arrest. And the result was no benefit. You couldn't get levels giving an infusion rapidly enough to make any sort of difference. So I agree that the peaks and valleys of epinephrine are a concern, but you don't get even to a peak, let alone a valley, if you just give the drug in an infused manner. So if there's not circulation, you probably are better off with bolus treatment than with an infusion.
One more epi question. This is coming from one of the Janik brothers in Alaska, a good friend of ours at the RA. Rob asks, any thoughts since you opened the door with your Pulp Fiction cartoon there on one of the slides? Any thoughts on intracardiac epi? And harken back to those days and tell us the tale of intracardiac epi.
Yeah. Well, I confess I have given intracardiac epi, so I have sinned, Andy, and I will have penance. There have been studies comparing central line with intracardiac, and central line beats intracardiac. There have not been great comparisons beyond that. But I think what I would say is the only benefit of giving epinephrine intracardiac, and by that I mean not into the muscle. You put epi in the muscle, the heart's going to fry. You're putting it in the chamber. And if you're getting it in the chamber, you're getting it in the central circulation. And that would be the same as giving it via central line. Faster and a bigger peak versus peripheral, where it's a slower entry and a slower peak. So I'd say I would put a central line in before I would go with intracardiac epi.
One of the comments that came in very early, especially during the IVIO, and I have to agree with it, is that those studies were somewhat unexpected, right? If you'd have asked me 3 years ago, we're doing these randomized trials, you have to bet on one side or the other, what are you going to put? I probably would have said that I think IV is probably going to be superior to IO, and that within IO, right, I would think humeral would be better than tibial, which I think is that was the preconceived notion at the time based on the limited data we had, which was very limited. And I think, that speaks to a couple things. One is the importance of doing the study and reporting your results, right? And actually examining these preconceived notions. And I wonder if you could just riff on that a little bit and sort of share your opinion on the importance of doing science to answer these basic questions.
Yeah, well, again, randomization is an equalizer in order to see if there's benefit from any sort of intervention. But I think you have to be really careful in randomized trials that you don't misinterpret a trial that showed no significant difference. That does not mean the two treatments, in this case, IV and IO, are identical. Because you have to really, in a superiority trial where you're comparing a new intervention against a standard one, in order to unseat it, you can either say it's superior or you can't prove superiority. You can't say equivalence. You have to do trials that are non-inferiority in nature to do that. And it comes down to the fact that the three trials that we talked about, all you can say is there's no evidence that IO is superior to IV. And if that's true and IV is the standard, then IV remains the standard in that case. So that's kind of just the statistical word on that. But I think again, it says even though something sounds sexy, it's nice to use a drill. It's nice to get something in you think faster. You have to be careful that the gizmos are not always the best way to go, and that it's the slow, steady pace, the hard work of clinical trials that really, I think, determine what the future is going to be like. The biggest mistakes I think we've made in resuscitation is when best intentions became standard of care. And we can then no longer question those best intentions because now they're expected and you can't unseat them. When we did the ALPS trial, we had a lot of flack by saying, how can you deprive a patient of an antiarrhythmic drug? It's standard of care. And the rationale here was saying the standard of care was adopted without ever knowing that there was a difference to be found. So I guess I'd say be enthusiastic about new science, be careful in applying it before it's actually proven. Clinical care is based on science, not always based on our latest whim or developments.
Very practical comment coming in right now. My agency pays $155 for an IO needle and pays $1.50 for an IV catheter, and that's a hundredfold difference. And that is a factor for many, many, many operations across the country, right? Where that budget is tight, and we're trying to keep things available, right? And keep the doors open and the lights on. And so I think that's a real factor and something to consider. The other comment is femoral IO placement. I don't know if you guys have talked about that. I know it's a topic we've started to explore here around the county, especially in peds, but I think there's growing literature around adult femoral IO. I don't know if you can speak to that, Peter.
Yeah, I guess the question, Andy, is does whether does a site of vascular access below the diaphragm compromise the ability to give a drug, whether it's tibial or femoral?
Yeah.
And I don't know the answer to that. My bias is that something in the upper extremities is more likely to get to the heart faster than something that has to travel up from the lower extremities. But I want to be careful because the Danish studies showed no clinical difference between tibial and humeral. And yet all the pharmacokinetic studies, and I only showed you a few, show just the opposite,
Yeah.
that humeral is better than tibial. So how do we mix that imbalance of clinical outcome and pharmacokinetic data? I think for now, I'm going to say putting the two together, if there's no downside in giving it humerally, why not? And if you can't get a humeral, get a tibial, go to where you can get bone.
Well, I think we're going to wrap it up there. Peter, thank you so much for joining us today. Really appreciate all the effort you put into this talk and this conversation and these questions. And it is an ongoing topic of research, an ongoing topic of commentary, and we will continue to bring this topic up from time to time and discuss it because it's really important. And it really can drive care for our patients and for our population. And hopefully we come to the right answer collectively as a scientific community. So thank you so much for putting it all together and chatting with us and being with us today. Really awesome. What a great crowd. What a great audience. This might be the most questions I've had to sort through in a long time, which is quite a record, Peter, and record attendance today. So fantastic. We will be back April 16th with our next Resuscitation Academy webinar. Very excited. We've got a great lineup over the next few months and just really, really excited to invite everybody in and share a little bit of what we're doing and what we're thinking about here at the RA. So we will see you April 16th. Thank you, Peter. Thank you, Tom, for joining us as always. And we'll see you next month.